Hi, welcome. Thank you for joining us for the first of our webinars concerning navigating Medicare's quality payment program, a comprehensive primer for physicians. We're very excited to bring this series together for you. I'm here with my colleagues today, Priya Lamba and Ray Quintero. We're going to be walking through this webinar for you. And we're going to be talking about kind of this full program that we've developed and then getting into many of the details related to the quality payment program. We're very appreciative for the Physicians Advocacy Institute's engagement on these issues. Just a little bit of background about us. You'll see there's a slide giving a little background about Healthspirium. In short, we are a Washington, D.C. based consulting legal services firm. And we have been working with PAI on a range of issues and topics related to the QPP. You'll see in your materials, and now I'm on slide 5, that we really have a full MACRA education series planned for you. The overall purpose of these materials is to provide a full suite of materials and resources that provide an overview of the core concepts and requirements and an in-depth discussion of important topics. And very important to the way we've been proceeding with this work is that we really want the best we can to not just talk about what the rules and regulations provide for, but actually to help physicians apply these requirements and think about them in relation to your own practices. So to do that, we have created first a MACRA overview. And this includes 5 webinars, including this one that will be rolling out in conjunction with the actual materials. We've got a range of follow-on products that are planned for early 2017. And these include in-depth one-pagers and monographs focused on specific topics of interest. And then we have a number of other things in development, including a guide to additional resources in your communities that you can access to learn more about the QPP and feel well prepared to engage in it. On slide 6, we have a range of acronyms. This may be a useful slide to refer back to from time to time. I won't go through this right now, but you'll see these acronyms used throughout the presentation. So now on slide 7, basically, what is it that you can expect to find in this presentation? The first thing that we do is, in a very abbreviated way, we want to go ahead and provide an overview of MACRA and specifically the QPP at 30,000 feet. So this is first about understanding, well, where did the QPP come from? Based on what CMS has said, what are, for instance, the goals of the new system? What are these 2 key pathways that you'll want to become familiar with? One is a MIPS pathway, which is a value-based payment program, and the other is an advanced alternative payment model program. You'll want to become very familiar with those 2 pathways, and we provide a lot of information on each. With respect to the different understanding of the different payment adjustments associated with each pathway. And then we also want to be fair in recognizing we've heard concerns from various PAI members, and I think it's important to acknowledge those. And those are also challenges that PAI is working on to help address. Another thing that you'll find in this presentation, really importantly, is 2017 is known as a transition year, and there are minimum reporting options that have been established for 2019, and we lay out what those options are. Again, that's for the 2017 transition year. And then we begin focusing on the first pathway itself, which is talking about MIPS, talking about the reporting timeline for MIPS, and then we talk about next steps and looking forward, and talk a little bit about thinking through, should I be selecting the MIPS pathway? In future presentations, we'll be talking about, for instance, the advanced APM track. But today, the in-depth discussion is going to focus more on MIPS. So MACRA at a 30,000 foot level, and now I'm on slide 9. So as many of you know, MACRA stands for the Medicare Access and CHIP Reauthorization Act of 2015. And as many of you know, one of the key reasons MACRA came into being was it replaced what were known as the annual updates under the sustainable growth rate formula, and it replaced that update system with what's referred to as the QPP. And what the new system does is it provides for new opportunities for positive and negative payment adjustments with respect to Medicare Part B payments. As we'll talk about, it ultimately will apply to all clinicians. And again, there'll be these two tracks that we talk about, the MIPS track and the advanced APM track, both of which can have financial implications. Another thing that the new system does is that it combines 3 existing quality performance programs into one. So it ultimately combines PQRS, the value-based payment modifier, and the meaningful use program all into a single program under the QPP. Just historically, the regulations for the QPP were finalized in November of 2016, and the final rule came into effect on January 1st, 2017. And the payment changes themselves begin in 2019, but they're based on the 2017 performance year, which is why the focus now is so intense with respect to the QPP and MACRA. In the future, we do expect that there may be modifications to the QPP program, and we'll be sure to be tracking those and be coming back to you with a discussion of those changes should they be made. Just real quickly on slide 10, this is really taken from CMS and the final rule. What are the goals of the new payment system? So from CMS's perspective, the first goal is to create a new Medicare payment system for physicians, and as I mentioned, ultimately other clinicians. It's supposed to apply across all specialties, and their goal is that it be meaningful and flexible, that it does improve patient outcomes and engage patients, that it encourages physicians to improve performance with a mix of carrots and sticks, that it increases the availability of and participation in risk-based models of care, supports broad physician participation, including in small and solo practices. And we know that's been a very important issue that we'll come back to from time to time. And then finally, a goal, again, from CMS's perspective, is to simplify a complex system of reporting and trying to simplify that as much as possible. I mentioned there's these 2 pathways, and now I'm on slide 11. I'm just going to skim the surface here because we're going to spend a lot of time in the future talking about these. As I mentioned, the MIPS, or merit-based incentive payment system, is what people refer to as a value-based payment system. It provides for fee-for-service annual updates. It has a new set of positive and negative performance payment adjustments, and those are based on 4 performance categories, and the weights for these change every year: cost, quality, improvement activities, advancing care information. And then there's also ways, even on the MIPS track, to participate in alternative payment models, or APMs. And those alternative payment models, or APMs in this context, are known as MIPS APMs, and they're distinguished from what's on the right-hand column, advanced APMs. On the separate track with respect to advanced APMs, the idea is this is the track that is intended to reward and encourage physicians to consider participation in advanced alternative payment models. And a little bit of what it does, if you're a physician or clinician that's participating in an advanced APM and you're participating in the advanced APM track, it results in enhanced fee-for-service annual updates. It exempts you automatically from the MIPS participation. And it also has, in terms of these underlying models, payment incentives for participating in certain of the ACO programs that CMS has and other advanced APMs. And again, in a future webinar, we're going to go all through that and identify which of those models qualify today as advanced APMs. It allows you to earn a 5% incentive if you're in the MIPS advanced APM program. And then, as I mentioned, you'll have a higher enhanced fee-for-service annual update. One thing to talk about here, again, just as you sort of think about the universe of the QPP, as it concerns advanced APMs, the QPP in some ways sits on top of underlying models. So the rules that apply to if you're participating in one of the Medicare Shared Savings Program, ACO models, or you're participating in CPC Plus or the oncology care model, or any other potential advanced APM, those rules still apply. The QPP sits on top of those rules and establishes other requirements that relate to, well, how much of my practice has to be an advanced APM in order to qualify for this track. And we'll get into those details later in future webinars. On the next slide, just to touch on this, we just lay out what the time frame is. This is slide number 12. And what we lay out is what the annual fee schedule updates look like. You'll see that there's a difference over the long run between the update for physicians that are participating in the MIPS track and physicians that are participating in the advanced APM track. But another thing that you'll see is that the potential for payment adjustments under MIPS continues forward in an indefinite manner and ultimately ramps up to plus or minus 9% of Part B payments. Whereas you'll see with respect to the advanced APM track, as it stands today, the incentive payments phase out over a period of time. So the first opportunity for performance incentive under the advanced APM track is in 2019 based on 2017. And then the last opportunity for the 5% incentive payment under the current rules phases out in 2024. So just something to be mindful of as you're considering potential participation in either of these tracks. On slide 13, real quickly, there have been concerns from PAI members, and these are important to acknowledge, but also potentially important points of improvement that could occur over time. One is a concern that there's a disconnect between what the QPP provides for and what physicians experience on a daily basis in their practice. In that vein, there's sometimes an unclear nexus between the programmatic and reporting requirements and actually seeing clinical improvement, uncertainty about how to implement, a lot of concern about the investment costs versus the benefits of participating in these programs, the fact that the program is supposed to stretch across a diverse range of physician practice types and specialties, and starting to talk about some of the risk-based models, some concern about measurement that actually accounts for risk. We mentioned before concerns related to small practices and whether the QPP further creates additional challenges for those that are practicing on a solo basis or small practice basis. And then in addition, it may heighten concerns that people have had with respect to EMR vendors and with respect to patients. It potentially doesn't increase the level of flexibility required to actually better engage with patients. So again, some of the concerns that we've heard from PAI members that we want to acknowledge. And then you can see on the next slide, there have obviously been some practical challenges with measurement and reporting. Again, we're going to work through a number of these issues and hopefully help people better understand what these challenges are. And then in terms of continuing on an ongoing basis to be trying to work through these issues and trying to help make sure that the QPP works as well as it can be, as it can. With that, I'm going to turn it over to my colleague, Priya, who's going to walk through some of the details with respect to the MIPS track.
Hi, everyone. My name is Priya Lamba, and I'm going to start with the merit-based incentive payment transition year minimum reporting options. So we are now on slide 16. For 2017, CMS has decided to offer some flexibility in how physicians can participate in the MIPS program and the advanced APM track as well, but mainly focusing on MIPS. So your four options are: you don't participate at all, you test and submit something, you do a partial year of participation, or you do a full year participation and submit for the entire year. We heavily recommend against not participating. If you don't participate, you automatically will receive a negative 4% payment adjustment off of all total Medicare Part B fee-for-service claims in 2019. And we recommend that you at least do the test reporting option to avoid that negative adjustment. With the test reporting option, we'll get into a little bit more detail on the next slide, but it just requires submitting a minimum amount of data, and that will at least get you a neutral, if not somewhat of a positive adjustment. The partial year reporting option is you submit data for 90 days worth of data, at least 90 days to 1 year. This will again help you avoid the negative payment adjustment, and under this option you can be eligible for a maximum positive payment adjustment just based off of the quality of the data that you're reporting and the performance scores that you will earn in those measurements. And this is something we will go into a bit of a deeper dive in the future materials that we produce on how the scoring works. The last option is submitting for a full year, again, avoiding the payment adjustment, and again, you can be eligible to receive a maximum payment, positive payment adjustment for 2017. As long as you submit something, you will be able to avoid the negative adjustment. That's the key message here, whether it's patient data for one patient or 90 or patient data for a full calendar year. Now, the test participation option on slide 17, if you, again, the minimum are the 3 reporting categories are quality, improvement activities, and advancing care information. So for quality, the minimum that you have to do is to report data for 1 patient for 1 quality measure. And this can be done through something as simple as your claims that you are already submitting for Medicare. You can submit this using a registry like a QCDR if you are participating in that, or submit this using your EHR if that is a capability that your EHR has. But the requirement is just 1 patient, regardless of whether or not the quality measure was done, but we're reporting some data on that patient. For the improvement activities, the minimum threshold is just reporting 1 activity, and this can be completed through attestation. So a lot of these activities, which we'll be diving deeper in the next couple of webinars, are things that you are probably already doing in your practice. So just going through them and trying to identify which ones you are already doing and just getting credit for doing those and avoiding an adjustment, a negative adjustment, is a fairly easy thing. And the last one is the advancing care information. As we'll cover going forward, there are 4 or 5 base measures for this category. And the minimum that you have to do for 2017 is just report on 1 patient for each of those 4 or 5 base measures. And these measures are essentially just numerator denominator or a yes/no measure. So you don't have to use the same patient for all 4 or 5 measures. You can have 4 or 5 different measures, patients for each of the different measures. But again, the minimum is just 1 patient for each of those. And then for the other 2 options, the partial and full year participation options, as I mentioned earlier, you are eligible to receive the maximum positive payment adjustment. And this just depends on your peers and how much information is being submitted by them and their quality scores and yours in comparison to them. Scoring we will be getting into in a second, but you have the option to report, and we encourage that if you are able to report for more than just the minimum, that you do consider the partial to full year participation options. I will now hand it over to Ray to do a little bit of a deeper dive into the MIPS track.
Thank you, Priya. As we work our way through slides 19 through 30, we'll be talking about the MIPS categories, participation and eligibility options, reporting mechanisms, as well as an overview of the approach to performance measurement. As was mentioned, the MIPS program is based on the previous quality reporting programs. The quality piece was based on PQRS. As you'll see on the slide number 19, it does mention the specifics of reporting measures as well as the score percentage that it accounts for as part of the MIPS program, which is 60% for the 2019 payment adjustment. The cost section, which is next, that's based on the value modifier. And the cost measures are being developed for 2018. The new data, there's no data that's being reported. The implementation eased at cost or 0% of the score for 2019. So that's one thing to keep in mind, but it will then become a part of your MIP score moving forward. Improvement activities, that is again a new category that's created, and as Priya mentioned, a lot of those activities are already being performed in your practices, so you can report a combination of those, and they're ranked in a chart. There are some that are high value, there are some that are medium value, and those will constitute 15% of your score for the 2019 payment adjustment. And then finally, advancing care information, which is based on meaningful use. And in that, you're required to report 4 or 5 measures for the base score, and that'll account for 25% of your score for the 2019 payment adjustment. This is seen as a challenging area for physicians, and as Gary mentioned earlier, PAI did mention that there are some concerns with this, but we will likely see some changes to this as we were already starting to see changes to the meaningful use program. Now, who does a QPP program affect? This is important for physicians to keep in mind as to who are eligible clinicians for 2017. Physicians are included, and the definition of who is a physician is listed on the slide. In addition to that, physician assistants, NPs, clinical nurse specialists, as well as certified registered nurse anesthetists. And there's an expansion of that list in 2019. And I won't go through that list, but it is included. So the list will continue to grow for the MIPS program, but most importantly for physicians, you are required to begin participating as of now. And there are some exemptions for the MIPS program. There are 3 particular types of exemptions, one of which are those that are newly enrolled physicians. And if you've enrolled for the first time, for example, for 2017, the second type is if you are a physician or if you're a group that falls below a low volume threshold that was set forth in the as part of the MIPS program. What that low volume threshold is if you have less than $30,000 in Part B allowed charges, or if you provide care to 100 or fewer Medicare Part B patients. And the final exemption for the MIPS program is if you are participating in the other track, as was mentioned before, which is advanced APMs. So again, if you're participating in advanced APMs, or if you meet either of the other 2 criteria, you are exempt. Otherwise, you are required to participate, or you will be subject to the penalties as defined by the MIPS program. Based upon the exemptions, specifically the low volume threshold, CMS estimates that 32% of physicians and other eligible clinicians will be exempt in 2017. And there will be a lookup tool that's available based upon your NPI number later this year on the QPP website, where you will be able to determine whether you fall below the low volume threshold. Now, participation options for physicians, there are basically 2. You can either participate as an individual physician or as part of your group. However, what's important to remember is that you have to participate in the same way across all of the 4 performance categories. So the 4 categories that were mentioned before, you have to participate in the same way, either as an individual or as a group. You cannot change. If you do decide to perform as an individual, you would report under your NPI number as well as a tax identification number, or the TIN of your practice to which they reassign your benefits. If you choose to practice as a group, which a group is defined as either 2 or more physicians with 2 or more NPIs who are part of the same practice with the same TIN, your reporting requirements and certain reporting options are available for groups of 25 or more physicians. As well, all physicians in the group would receive the same aggregated scoring and corresponding adjustment across the group. And finally, additionally, physicians in the practice, you have to participate the same way individually or as a group. So again, if you are a part of a practice that chooses to participate as a group, every physician within the practice would have to participate in that manner. There would not be some physicians participating as part of the group and then others allowed to participate as individual physicians. They would have to all participate the same way. And the example on the bottom of slide 22 provides some detail on that. The reporting mechanisms and options slide provides some details on the specifics on the categories of reporting. For example, for the quality category under individual as well as group, it lists the specific ways in which you can report as an individual. As an individual in the quality category, you can either choose to report with claims, with your qualified clinical data registry, with a qualified registry, or through your EHR. And with your group, it does provide the list as well. And improvement activities as well as cost, it does provide your reporting options as well. And the next slide provides some pros and cons to help you in selecting what your best option might be for each of these individual reporting mechanisms. And again, as you review these will vary depending upon your particular situation as well as your practice. So for example, in looking at your EHR, many of you are already using your EHR in your daily practice, and that would provide for an easy opportunity for a vendor to submit data on your behalf. However, you have to ensure that your vendor will correctly and accurately submit the information. And there's limited availability of quality measures that can be reported via an EHR. So all of those considerations have to be taken into account as you're determining whether you're going to utilize your EHR as a reporting mechanism versus potentially using a QCDR or a qualified registry. But again, you do also need to look at what is available to you, whether you're reporting as an individual or group, because not all reporting mechanisms are available for each reporting type as well as for each category. The next section will provide information on the approach to performance measurement and payment incentives. The essentials, again, we've talked about the combination of the reporting programs. The intent of MACRA overall, as well as the QPP, was to streamline as well as to reduce some of the administrative burden that existed in the reporting programs. That is yet to be determined at this point. However, the 4 categories, again, quality, advancing care information, cost, and improvement activities, are intended to do so. As a participating physicians in MIPS, your final score will be based on your combined weighted average across all categories. And again, for the first year, cost will not be considered a part of that score. It is given a 0, but it will then be included moving forward. And CMS will compare that score to an overall performance threshold, and then they will utilize that to determine whether or not you as a physician receive a positive, neutral, or negative payment adjustment. And then these adjustments will be made in a budget neutral fashion across all physicians participating in the program. So there are winners as well as losers in the program. Physicians will receive your score for each of the 4 performance categories in 2017. Again, that's only for the 3 categories since cost is not included. 2018 and onward, it will include cost, as I've already mentioned. Weights do apply to each category to constitute the final score of 100 points. And CMS will publish in advance the threshold of points out of that 100 that you must achieve as part of your score to achieve that negative final payment adjustment. And for 2017, they have already published that threshold, and the adjustment is only 3 out of 100 total points. So what that accounts for is only reporting 1 quality measure at minimum or improvement activity in order to meet that 3 as part of that threshold. For 2018 and onward, the threshold determination will be made using mean or median final scores from the prior period. In addition to that, as part of the MACRA legislation, Congress did make extra bonus payments available for those that were high performers in the program. And the top 25% of performers above the performance threshold are eligible to receive up to 500 million available in aggregate payments, and that is available each year only from 2019 to 2024 in the MIPS program. And if you're above the performance threshold, you'll receive at least 0.5%, but you could receive up to an additional 10% in bonus payments. So the chart that was shown earlier that lists the potential payment adjustments under the MIPS program, there is a potential of receiving an additional 10% on top of what is listed for those that are considered exceptional performers. And those physicians, to the contrary, that receive less than 25% of the threshold will receive the maximum negative payment adjustment each year, which is in 2019, 4%, and going up to 9% in 2024. And finally, in looking at the category weights, the charts on slide number 29 show 2017 and 2018. Again, 2017 does not include costs, so advancing care information includes 25%, quality is at 60%, and improvement activities is at 15%. And that adjusts in 2018 in order to bring in cost, which cost will be at 10%. Quality then decreases to 50%. Improvement activities remains at 15%, and advancing care information does remain at 25%. So the only change in 2018 is that cost does account for 10%, and therefore quality goes down 10% to then be 50%. And then 2019 and beyond, cost goes up to 30%, quality goes down to 30%, ACI remains at 25%, and improvement activities stays at 15% as well. So as you'll see, over the years, cost does become increasingly important for physicians, and so that will be a factor that physicians will have to be much more accountable for, as well as much more conscious for. And with that, I will hand it back over to Priya to talk about the timeline.
Thank you, Ray. So we are now on slide 31, and as you will see, we've laid out the timeline just for the first 2 years with some general key dates that you should keep in mind. As you'll see, the performance year starts every January and ends on the 31st, but you will have at least some additional time to submit the data, especially if you're using the QCDR, Qualified Clinical Data Registry, a qualified registry, an EHR CMS web interface for submitting the data. And so key things that you should keep an eye out for 2017 is keeping an eye out for when CMS notifies and makes available its lookup tool. This is not on here, but we are hoping that this will happen sometime in the March or spring. If you are already interested in participating in a QCDR, CMS will be publishing its list of QCDRs and registries that will be available within the next couple of weeks. So keep an eye out for that as well. And those reporting options, you can then register and start submitting your data through them. Another thing you should keep an eye out for is if you are participating in an advanced APM, CMS is going to have 3 lookup periods when it will look at who is participating in these APM models, who is on those participation lists, and it will make 3 QPPQ determinations, so qualified participant and partially qualifying participant determinations, which means that providers and physicians who meet those thresholds that CMS will be calculating will automatically be exempt from MIPS. And so you will not have to participate. Only qualifying participants will be able to earn the 5% incentive payment, but the partially qualifying will also be exempt and will not have to participate in the different categories that we have been covering so far. The last day to begin your 90-day or partial year reporting, if you're interested in that option for 2017, is October 2nd. So you have some time between now and October 2nd to assess what capabilities your practice already has in place, what processes you may need to implement to meet the reporting requirements for the 3 different categories: quality, advancing care information, and cost. So we encourage that you look at that and make an assessment of whether you can at least participate for the 90-day reporting period and be eligible to earn somewhat of a positive payment adjustment. As Ray mentioned, it is budget neutral, so it will just depend on how many others are participating in the program and how many negative payment adjustments are collected. The end of the performance year is December 31st, 2017. You will receive your feedback reports on 2017 performance in the fall of 2018. We know that this is another issue that has been raised a couple of times, and it's that the feedback reports are not being offered soon enough and early enough for practices and physicians to make changes to increase their chances for getting a positive payment adjustment in the following year. But as of now, the timeline still remains that they will be issued in the fall after the end of the performance year. And then the final payment adjustment is then 2 years from the performance year. So the 2017 performance will determine your 2019 payment adjustment. And that will be applied beginning January 1st. So next steps in looking forward, we are now on slide 33. So should I select the MIPS pathway? One, the first thing you should determine is whether you are exempt from MIPS participation. Do you meet the low volume threshold requirements? Are you a new Medicare participant? Are you participating in advanced APM? So make those determinations and you will be exempt. And this will be an easier way for you to do this before CMS even makes this lookup tool available, but that will be an alternative option. Pick your quality reporting pace for 2017. Evaluate your practice readiness and determine if you can do at least the test or the partial, if not the full year reporting for 2017. And then select the best reporting mechanisms by evaluating your resources. The key here is, although you must participate as an individual or group across all 4 categories, how you report across all 4 categories can be different. So you could use a QCDR for the quality, your EHR to meet the ACI, advancing care information, and attestation to submit your information for the clinical practice improvement activities category. So just determining what's available to you, what you are already doing, and which categories and measures is easier for you to submit data on based off of what your practice readiness is at the moment. And then consider whether an advanced APM option is feasible before making the final decision. As we just mentioned, CMS will have 3 look-up periods or evaluation periods for advanced APM participation. So if that is something that is within reach, maybe that is an option that you could pursue even for 2017. If some physicians in your practice are already participating, you may want to consider joining the advanced APM track as well, as long as when you are on that participation list at some point in 2017 and meet the QP or PQ thresholds, you will be able to be exempt from MIPS. Again, just there are more strategical considerations that must be taken into consideration here. And we will dive into those in future webinars about how to think about that, but just something to think about. If you're not participating in advanced APM, again, what we already discussed, and if you are, continue participating. Look out for the participation list and CMS determinations, and determine if you are a PQ, if maybe the MIPS APM track, which we'll go into, is another good option for you, or if you want to just participate as a MIPS. So that's what we have for now. As we mentioned on slide 34, CMS, PAI, and Healthsperian will be making additional resources available. We have a lot of follow-on products about minimum reporting for 2017 available on PAI's QPP website. What you have to do, the minimum for 2017 for quality, ACI, and for the improvement activities category in a much more applied way, so you can really understand, take what's there and apply it in your practice. We are also developing guides to additional resources in the physician communities. We have a searchable FAQ document on the PAI website that is a living document and will be updated continuously as we receive more questions from you guys. And regular email updates will be provided on materials and resources and news from CMS and other organizations that will be helpful for QPP. We will now answer some common questions that we have been receiving. I will let Ray take the lead on the first one.
Thank you, Priya. And we certainly are receiving a lot of questions, and we know physicians have a lot of questions, and we'll do our best to address many of them. The first common question is, if an eligible clinician only wants to report the minimum to avoid a penalty, what are the options? We did touch on this on slide number 17, which is available to you to look back at in terms of the minimal test participation for 2017, is just submit something to avoid the 4% payment adjustment. There are 3 specific options that you can choose, either quality or improvement activities or advancing care information. So there are options available to you, especially for 2017 as a transition year. And the hope from CMS is that physicians will really use this as a transition year to test out their options and to submit something not only to avoid the penalty, but to become accustomed to how the QPP works and how the MIPS reporting option does function.
The second question that we have received is, when will CMS notify individuals who are exempt in 2017? As we mentioned, CMS did say that they will put out a lookup tool for physicians to determine if they are exempt based off of their TIN and PI. This was supposed to be made available this past winter, early January. We are now in April, and CMS has not indicated exactly when this will be made available. What they're hoping sometime this spring, I think, is a new deadline. That will be made available on PAI's QPP website. So there will be a link that will take you there once that is available on CMS's website.
And many physicians are also wondering whether or not they can participate in MIPS without having an EHR. Yes, you can, and you can do so via the claims reporting option, for example. We will be providing additional details as to how to do so, but as we mentioned before, there are multiple reporting options for each of the areas within MIPS, and specifically without an EHR, you can certainly do so, especially in the early parts of the QPP program.
Another question we've received is, if I am in an alternative payment model, an APM such as an ACO, do I still have to participate in MIPS? The answer here is not as straightforward as we'd like it to be. There are many APMs out there. So the first step is determining whether the APM you're participating in, including the ACO, is determined to be an advanced APM model under the QPP. Just to note specifically on ACOs, Medicare Shared Savings Program Track 1 ACOs are not considered advanced APMs. So those participants will still have to participate in MIPS either under the MIPS pathway or what we will describe later is the MIPS APM pathway. Medicare Shared Savings Program Tracks 2 and 3 and Next-Gen ACOs are considered advanced APMs for QPP purposes, and whether your participation there exempts you from MIPS depends on your on the Medicare patients or Medicare payments that you're receiving through those advanced APM models, and that those are what determine these QPPQ thresholds we keep referring to. We do have another webinar available on that if you're interested in learning more additional details there. And then if you are in the advanced APM and you are determined at a lower end, you may still have to participate in MIPS just if you don't meet those thresholds. So it's a step-by-step process that must be taken into consideration. Again, not all APMs are considered advanced APMs, so that would definitely be the first step, is determining whether you are in an advanced APM versus an APM such as IAH, for example, or BPCI.
And the final question that we'll address on today's webinar is, if more than half of the physicians in a group practice choose not to participate or do not successfully participate, is everyone in the practice subject to a penalty? First off, that depends as to whether or not the physicians in the practice are reporting as individuals or as a group. If the physicians are reporting as individuals, they will be scored as individuals. So therefore, it depends on how they perform individually, to say it in an easy way. If they're performing as a group, they will be subject to the performance across the entire group and will be scored as such. The practice itself will determine that level of reporting. And again, if you are reporting as a group, you will report as a group across all categories, as well as if you're performing as an individual, you will do the same. And the evaluation of who will report, of how you will report, as well as whether or not you will be most successful reporting in the individual setting or as a group setting, should be a part of the practice evaluation that you consider in terms of what your practice decides to do. And those should be considerations that you go through as to whether or not you decide to report as a group, or if it makes better sense for your particular practice to report as individuals. And again, the 2017 transition options are easy. They're meant to be in order to provide physicians an entry point into MIPS reporting. So again, these do not cover all of the questions that are out there. We know that there are many burning questions, and there will continue to be, and we'll do our best to continue to answer those questions as we develop our FAQ, and it will be continually updated on the PAI website. So with that, we do want to thank you again for your time on behalf of both PAI as well as Healthsperian. And we urge you to continue visiting the PAI website, which is listed on the slide before you, for continuous updates, as well as additional resources that we will be providing that we have mentioned earlier in this webinar. So again, thank you and have a good day.
Thank you.